thank you so much for inviting me to speak. So I just wanted to reflect a little bit on what's all the introductory bits. I feel very strongly that we need to... research into practice is always what we hear about. I quite like to think about practice into research as well. I suppose I feel it's always talked about in that direction, and I'm sometimes quite uncomfortable with that. I'm delighted that traditionally health-orientated networks and frameworks are now encouraging and engaging with social care and social workers. I think that's a long overdue move. And the other thing I want to say is I'm going to be unpacking some assumptions. I completely agree with what's already been said about assumptions. And I think there's an awful lot of assumptions about older people, about health conditions, and about carers, and about social care. So, I think I'll just kick off. Yes, I've got to advertise my book. Every opportunity I get, I've got to do that. I'm told by the publisher. So I did this in 2020, and I'll be referencing it a little bit as we go through. But if you sign up to Policy Press newsletters, you get 25% off, not just my book, all Policy Press stuff. So, now I'm hoping to get through three things. If I don't have time, I will simply be sticking with the first two, which is the social lens on at least two health conditions, more common in later life, family carers, and if I've got time, I want to have a little bit of a think about social care services and how we understand them and what their role is. And then we'll have some time for questions. I just wanted to begin by reminding us, and I really don't think I do need to do this to this audience, that we are living in, we have an ageing population. Now, when I talk to students, they think that means people live longer. Well, it is a little bit about that, but it's mainly not. It's mainly about the fact that there are fewer younger people than older people. That's what, it's a social phenomenon rather than an individual phenomenon. But of course, what that does is the kind of narrative about you being old and using up services, it becomes quite easily a kind of blame narrative. But in fact, if you want to get into the blame game, it's the fact that we don't have enough young people, and have enough children to balance out the older population, frankly. But it is true that more older people have chronic long-term conditions than younger people. I'll come on in a second to challenge the age equals illness narrative. And there are more and more people with what are called frailty. Again, I'll come back to that in a minute, which, as again, you will know in this room, is a definition, if you like. It's not really an illness, it's a sort of label. I think it probably is a label, which captures the fact that an older person may have 3 or more comorbid conditions. And I've discovered recently there's this new one called sarcopenia, which apparently is sort of struggling with life or finding it difficult to sort of manage. And again, I kind of question really, like, is it a useful label? Well, you might say, yes, it is. It's a way of capturing something that is perhaps common. Apparently affects, again, a huge range, because how do we even measure something as broad as that? Between 11 and 50% of people over 18. The other thing I want to mention, of course, is dementia. And again, I'll come back to that in a minute. There are increasing numbers of people with dementia, and that is going to become a huge figure by 2051, 2 million people estimated to be. But we've also got increasing numbers of older people, and this is perhaps a comment more to the social work or social care staff here, of people facing situations of risk, of uncertainty. That's before we even had COVID into the agenda. Of ill health, of multiple conditions, of transitions. And the transition isn't just from one physical space to another, it's a transition to being elderly, being labelled, being widowed. And complexity, lots of complexity. Complexity around money, around status, around labels, around who you see, what staff you see, who comes into your home to look after you. Your carer may die. So lots of issues, lots of complex issues older people are facing. We know that over 1/3 of the UK's 10.5 million carers are older people themselves. And again, I'll come back to this a little bit later, but it's just worth highlighting that. And the older population is increasingly diverse and heterogeneous. There are increasing numbers of older people living alone, people who are what's labelled, if you like, ageing without children. So if we think that families are there to support mainly adult children looking after their parents, and you haven't got a child, your child's in Australia, who's going to do the caring? So again, that's an assumption. We've got higher numbers of people from black and ethnic minority populations and higher numbers of people from lesbian, gay and transgendered populations ageing. So, of course, the bigger the population, the more heterogeneous it is. Right, I want to now start to think about the social lens. What can the social lens add to our understanding of later life and health issues? The social lens has two facets. The role played by social inequalities is one of the facets, and the other facet is what I might call a sociologically informed perspective. Risks of ill health in later life are much more complicated than age itself. Despite the overall improvements in living standards for older people in the UK since the end of World War II, two important trends are important to take account of. One is that there is clear evidence of large inequalities in health and well-being in the older population, arising from life course and age-related inequalities combined. And these mainly relate, or the easiest way of capturing them is through the lens of socio-economic position, but it also relates to ethnicity, to gender, and to where you live. There are huge geographical disparities in health and well-being outcomes. And that's already been alluded to by a couple of the introductory talks. Michael Marmot, in particular, argues strongly that inequalities in health derive from inequalities in society. And as I mentioned, most of the evidence relates to socioeconomic status. The other point is that inequalities are widening. There is a growing gap between the older population that have a decent income and access to resources and support, and those who live on a low income and have very limited access to resources, what Chris Phillipson calls two worlds in old age. If you're poor when you get to retirement age, you're going to be poor for the rest of your life. What we know is that long-term exposure to socioeconomic disadvantage is strongly correlated with poor health outcomes. That's true across the life course. Again, I'm not telling you anything you don't already know. But somehow we sort of forget about that when people get to be old. It's like, oh, well, they're ill because they're old. But actually, they're usually ill because of what's happened across their life course. And it's strongly correlated with shorter life expectancy and shorter healthy life expectancy. So if you're a poor child, you're more likely to become a poor young adult and a poor middle-aged person and a poor older person. So these are trajectories. So if I was asked ever, if I wanted to reduce mental ill health in later life, and what would I do? I would reduce child poverty straight off. Because once you can never delete the damage done in childhood. And again, those of you who are doing research in this area, please feel free to challenge me. There's a sort of fantasy that if you perhaps are lucky or you quote, marry well or whatever, that somehow the damage done in your childhood will be deleted. That's not the case. Evidence is very powerfully saying that once you have a really damaged childhood, a very disadvantaged childhood, the damage done there is going to carry with you for the rest of your life. And I've got some stark stats here about the difference between living in Kensington and Chelsea and living in inner city Glasgow is that you can expect to live much longer in KNC and much longer healthy. It's not just about dying younger, it's also about having a longer, healthier life. And there is a particular relationship between socioeconomic status and frailty, illustrated here by this graph. What we know is that poorer groups show much higher levels of frailty at a much younger chronological age. 10 to 15 years younger. So when you're seeing someone who's frail, just think about a little bit about they're 60 and they're frail. And yesterday I saw someone who was 80 and they're actually quite fit. They're beginning to be a bit frail. What's that about? It's not about lifestyle choice. This is what I would substantially challenge. This is the kind of narrative now. You've eaten badly, you haven't exercised enough. I'm arguing these are life course, structurally determined disadvantages for the people that end up being frail in their 60s. The other issue is that the gap between the rich and the poor, and I mentioned this already, is widening, and frailty is a good example of that. So we've got more and more older people from disadvantaged backgrounds becoming frailer younger, and we've got better off people with advantaged life courses living longer with healthier lives and becoming frailer at ever older ages. So the gap is widening. Yes. Now, dementia is the other condition I just want to spend a little bit of time thinking about. It is age-related. There is no question of that. And people sort of say to me, well, yes, but if you're challenging the age-related correlation, but it's there. There's no question about it. But let me just disrupt a little bit. There is growing evidence that dementia is an outcome of an accumulation of life course risks over many decades as well. So the Lancet Commission on Dementia, again, I'm sure some of you are familiar with this, suggests that at least 35% of all dementia cases could be prevented if 9 modifiable risk factors were fully eliminated. I'm not going to read them, they're on the slide. What's worth noting is that some of those are about structural inequality. Lower levels of education, for example. And we know that diabetes is much more prevalent in disadvantaged populations. And it's also related, apparently, to mental health issues such as midlife depression and physical risk factors such as diabetes and obesity. Now, they're a bit of a mixture, aren't they? Part about lifestyle and part about life course. But they are linked. Some of them are really quite strongly linked to inequalities, social inequalities. So I guess what I'm saying here is, yes, there is an age-related link, but it's important to take account of life course issues too. And if we really are serious about preventing, reducing the number of people with dementia, we need to think about the life course, not just what happens in later life. Now, I want to just highlight a couple of issues in relationship to the frailty discourse. Grenier and others make a distinction between being frail and feeling frail. So the frailty, whether someone's frail or not, is often, determined, if you like, by some sort of clinical assessment, perhaps not necessarily a tick box, but a sort of a form of some sort, a measure of some sort. Whereas feeling frail relates to the older person's emotional self, their responses to the illness, their lived experience of the condition. It's a socially determined experiential status. And older people themselves are often very well aware of the risks of identifying as frail. Who wants to identify as frail? It's not a positive thing to be. And there's certainly evidence that very elderly people who are probably frail by any clinical assessment would resist identifying as frail because they associate it themselves with a failure, with negativity, with having done something wrong and maybe they could have avoided it. So there are psychological consequences of identifying as frail. And as Gilliard and Higgs say, for many people it's associated with being of a failed old age as well as a frailed old age. Now, you could say, and you could argue this, and please do come back to me on this in the questions. Well, this is all very well, but, so what about it, really? What can I do if I'm a practitioner or a manager? So I think it's about appreciating the role played by life course risks. So frailty is more complex than just a narrative about old age. Often the lived experience, and I'm sure this isn't true for the people in this room, but sometimes practice doesn't take a sufficient account of the older person's own experience of that condition. What is it like to be frail? What is your own experience of that condition? And thinking about support that takes account of that is sensitive to that person's own emotional journey. Adjusting care and support to take account of that journey. and building a bridge between the more perhaps medical functional approach and the more emotional meaning-making approach that matter to older people themselves. Now, this is blatantly me advertising my book. This is a model that I developed. And what I'm doing here is I'm trying to present a widening lens. I didn't, by the way, do the graphics, just to be clear about it. You can see from my slides I'm not particularly oriented in the graphics part. But the aim is to sort of take account of the fact that we've widened the lens around dementia. We're more inclined to see it as a complex, nuanced condition than we once did. Now, I'm not going to go into the model in any depth, you'll be delighted to hear, but I just wanted to highlight a couple of things. First of all, that I think the relational, the lived experience, the sociological has played a psychological as well, has played a greater part as time's gone on. Particular contributions have been made by Kitwood's seminal work, again, most of you will be familiar with that, where he talked about malignant social psychology and personhood. He emphasised the person as opposed to the dementia, and the social and psychological impact of dementia as well as the physical and medical. So he pioneered that, really. He was speaking into a very biomedical discourse at the time. And in the 2000s, the social model of disability has helped to raise the profile and rights of people living with dementia. By framing dementia as a disability, the problem, in quotes, is transferred from the individual and the family to out there, the community, society, rules, access to services, and so on. Pursuing a social model challenges the deficit-based thinking and the social construction of dementia as a wholly negative condition shaped by fear, stigma, and exclusion. And it helps to refocus the care system, if you like, towards what can be done to engage, to include, to think about dementia differently, and encourages a more nuanced, personalised approach to care and support. And, for example, it demands us to engage with communicating with somebody with advanced dementia in a more creative way. Now, this may not always happen. I'm not naive. I realise this doesn't always happen. There isn't the time. There's a hospital bed that needs to be emptied and all of that. But the social model helps us think that through in a different way. And then lastly, I just want to say something about social citizenship, which, if you like, is the more recent kind of arrival on the scene. Developed by Bartlett and O'Connor, who describe it as a relationship, practice, or status in which a person with dementia is entitled to experience freedom from discrimination and to have opportunities to grow and participate in life to the fullest extent possible. It involves justice, recognition of social position, and the upholding of personhood rights and a fluid degree of responsibility for shaping events at a personal and societal level. So it's a more politically orientated lens. It explicitly recognises that the experience of living with dementia is a nuanced one and can be influenced by gender, ethnicity, and life course issues. And it also recognises that issues that may precede dementia, like abuse, domestic violence or domestic abuse, continue to have resonance for that person. Dementia doesn't become everything. That's the other problem with dementia as a label, isn't it? It tends to eclipse everything else that's both gone before, but about that person. A lot of people resist, as they do with frailty, resist being diagnosed with dementia because they fear that that is all people will see of them. But no, they weren't the teacher, they didn't play golf, they weren't this person with this life and characteristics. Now, you could say to me, well, actually, I'm getting the first two bits, but the social citizenship, that's all very lovely and well, but how does it translate into practice? And the answer is, that's tricky. It can be criticised for being lovely in theory, but trickier in practice. They would argue, I'm talking about Bartlett and O'Connor, that ways that you can challenge it directly are things like explicitly acknowledging there aren't enough services, talking about the fact that cuts have a direct impact on people's health and well-being. With service users and patients, I'm talking about, as well as with your own managers. So they're sort of saying you need to bring some of that, those bigger picture stuff into the discourse. Right, Now, I want to make a point about social care. I'll come back to this if there's time. There's a lot of, I probably won't then. There's a lot of evidence that social care services, which by the way is really a very uniquely UK label. Just for a second, if you go to another country, and again you'll know this, for example, America or the rest of Europe, you talk about social care, people go, well, what do you mean by that then? Is that care? Well, because we've got essence, because we've got the NHS, just everything that is about care that isn't inside the NHS is sort of social care. But of course, it's a kind of false. It's false in all sorts of ways. It's false for the person experiencing care, for a start. The person that comes on a Monday called Daisy, who I pay for, and the lady that comes on Wednesday, who I think is from the NHS, I don't, but they seem to do the same. So there's all sorts of issues about that. But what is clear about dementia is that social care services play a much greater role in the lives and health and well-being of people with dementia than medical services do. It's just a fact. Most people with advanced dementia who get care and support get it via social care, not via the NHS. They might get a bit from the NHS, but the vast majority of their care will be from social care services. So there's a strong case for really arguing for less investment in medicine and probably less hysteria about things like diagnosis and much more investment in social care. And I'm not even going to insult you by listing those improvements because I'm sure you would all agree that they are essential. We keep saying they're essential, by the way, don't we, all the time? Politicians even say it, and yet we are still in a position where recruiting and retaining staff, particularly in domiciliary care, I think someone's talking about that later, and care homes is almost, in some places, Isle of Wight being one example, they have run out of people to work in care. There are no people left. Right, family carers. I'm going to gallop through this. Some stats. By the way, you can have the slide. So don't please sort of, as it were, think and perhaps listen if you're still awake. Just a few facts there about carers. There's lots of them and a growing number, and more of them are older. And a load of people were added in the pandemic for reasons that are obvious. Some of them are carried on being carers, of course. And lots of carers do lots and lots of hours of care. And they're doing more care for more hours, and they're doing more complex tasks because care services have withdrawn. Not talking about yesterday or the week before, over the last 10 years. Now, policymakers have an ambivalent relationship with carers, I would argue. On the one hand, they need them to carry on caring, because if unpaid carers, family carers didn't do care, then it would cost to us a lot of money. So they kind of want to keep them caring, and I'll come back to this in a minute. At the same time, there is a policy aim to protect carers from some of the more extreme harms that can come to carers. Poor health themselves, poverty, having to leave work. In fact, I was once challenged by a policymaker who said, if I could ever solve how to keep middle-aged carers in employment and keep them caring, then he'd basically give me an OB or something like that. So, it's like there are these tensions. The middle-aged carer who's at the peak of their game often can't carry on working because they've got to look after their elderly mother. That's a classic challenge. So there's tensions. And there's also a tension between the NHS and social care. I've mentioned that already. Savage cuts, as we all know, in the last decade or so. So getting access to publicly funded social care is very, very challenging. I haven't got to tell this audience this. To go back to the two worlds in old age comment I made earlier, if you've got enough money, you come near or by the local authority. You buy your own care in. So that's one population of older people. The people that end up being at the door of the local authority are people who generally are in group 2. They're poorer, they have fewer resources, they probably have fewer family members to support them, and they're probably much further down the path because you wouldn't get in if you didn't have extremely high levels of need. Now, what we know is that carers themselves have also experienced cuts. So not only is the person they're looking after getting less, they are also getting less. And we think only about 10% of carers get an assessment at all. I think I'll leave this. I quite like this, but it's really about language. It's about language we use about carers. It's always positive and rosy. It's always marvellous. So somehow you were abused by your husband for 40 years and you're going to be this rosy, lovely, positive carer. So, there's something uncomfortable about that narrative. It's heroic. You're doing out of love and obligation. Now, people are doing it out of those motives, absolutely. But where's the fact that the marriage was always rubbish? Now, where? So your stepdad sexually abused you when you were a kid, and somehow you're supposed to be this marvelous carer. So there's just lots of things there about us constructing care as positive, and by the way, good. There's a fantasy: formal care bad, informal care good. There is no evidence for this. Probably running out of time really badly, but I do want to. This I really do want to spend a little bit of time on. Some seminal work done by actually a colleague from Kent, Julia Twigg, and her colleague Carl Atkin in the mid-1990s, where she said services construct carers in the following ways. They're either resources, they're co-workers, they're co-clients, or they're superseded, they're sort of not needed. And you've kind of added a sort of expert kind of narrative to this carer's description as well these days. But interestingly, they're not an expert in being a carer as such, or even their lived experience. It's about being an expert in the person they're looking after. Well, for those of you who've got relatives, or think about perhaps a partner or a parent, is that how you see them? Is it? So you can become an expert in your mum and your that's not how relationships work. So there's again, it's all part of the we need to sort of emphasise the positivities of caring, the benefits of caring. The family is the best site of care, which often is, but not always. I'm arguing this is a political narrative that's being pushed. Evidence from research suggests that carers feel themselves to be regarded and feel themselves to be treated as a free resource. And what we do know is that in local authority assessments, the carer's input is disregarded, which I think is absolute evidence that their role is free care, and then we add on to that. It's not in addition to, it is in addition to, it's not complementing or supplementing. So the carer's role is you do X, Y, and Z, and then we'll come along and do a bit of extra. So very much carer as resource, free resource. Now, I think it's getting even worse. I think we're now straying very overtly into territory where we are overtly recruiting carers. And don't forget they're unpaid. Are there lots of circumstances where you recruit people? Yes, you might do as volunteers, but carers don't feel themselves to volunteer to be carers. Often they say, I did not have a choice about it. So we are offering carers training to do lifting and handling and skills for cares. Oh, yes, come on down and do lots of training. And we are, I think, colluding with that. So someone of 85 who's frail, looking after their very elderly wife, we're all right with that, are we? That's okay, is it? We're also transferring risk and responsibility. Under the narrative of self-directed care and family know best and all that, we're transferring risk and responsibility for choices about services. And Clark and others argue that's a devolution of stress, so we're devolving stress onto the service user and carer. I mean, thinking about the elderly carer whose wife's got dementia, this person is then, here's a list of home care services, Mr. Jones. Off you go. And the stress can have an impact on people's mental health, particularly mental health, but also physical health. And we're also expecting carers to do more and more complex tasks that used to be done by actually nurses. Not even, as it were, not home care workers, but actual nurses used to do monitoring of medication, and now we're expecting carers, and it's just a quote here from, I think it was a nurse actually, which it says there, the nurse. So, you will need to give him his drugs when I'm not here. I'll show you what to do. You will have to be me when I am not here. So this is a lot of responsibility. In America, carers are being sued, by the way, you'll be delighted to hear, for accidentally overdosing a relative. So they're being sued by other family members. So I'm just saying I think we need to be very wary of this drift into you off you go and do that. And often this emphasis in policy on carers putting their hands on, I'm a carer, could I have some help over here, please? No, most carers don't identify as being, particularly older carers. They resist the label. I'm his wife, or I'm his daughter, particularly older spouse carers. They're very reluctant to identify as carers. So that's not the way forward. They worry that that will subsume everything about them. I don't want to be seen. I don't want my wife to be seen as a burden, so I don't want to talk about her in that way. And I think as well, we are completely ignoring the relational nature, embedded relational life course nature of caring. People do it out of love and duty and obligation, and I've said earlier that it's not always rosy and lovely, but it is embedded in often a lifelong relationship of some kind. And I think the carer-user, we don't see it as a dyadic relationship. Well, how many people in marriages, you go home to your partner, or perhaps you live with a parent. Your world is together. Most of what you do is a dyadic experience, and yet somehow in our systems it's carer and user. Well, I'm involved in a project actually at the University of Kent looking at dyadic assessment. So I think we are beginning to move a little bit in that direction. But it's the relational nature. You wouldn't be doing caring if you weren't in a relationship. Also, people co-care. That's the other thing. I'm sure you've all in your careers and practice come across often elderly couples. Perhaps one person's got dementia, the other one's frail, and somehow the person who's frail directs the person with dementia to do things, and they kind of rub along. They sort of get along all right. They kind of manage. So it's about recognising which form do I? Which one's the user? Well, that's not how it is for those people. Okay, I think I'm gonna have to leave the social care bit. That's fine. All I wanted to say was really that older people rely on social care services. I'm usually better at the timing than this, actually. I just couldn't get rid of things. So just a couple of final reflections then. So I think the social lens helps to challenge lazy assumptions about links between health and old age, helps us to think about the role of the life course and inequalities in influencing health outcomes. In fact, I argue in my book that mental health in later life is an outcome of a life. And it helps us to engage, I think, with user and carers' lived experience. I'm sure you will do that anyway, but it's something about reframing it a little bit, refocusing it to take account of the lived experience, the perspective of that older person, and what matters to them. And also the dyadic lens that I've just been talking about as well. And I think we've really got to challenge this drift towards, I would call it, exploiting family carers. I think we really are at a point now where we're just putting onto carers. I think that's an argument for there's a human rights agenda, which I'm not going to go into here, but I'm interested in thinking that through a little bit. But at what point do we say, actually, imagine if it was a child, a 12-year-old child? Like that's the other group that people go, oh, you can't, oh, poor child, can't do that to children. Well, what are the limits? What are the limits of what we can expect of family carers? We need to share responsibility for care with carers. We need to go back to that. And the last I was going to talk about, the critical importance of social care services and staff to the lives and well-being of older people and their families. If you ever have a conversation with anyone about social care, within 2 seconds of that conversation, people go, oh, we can't afford that. It's always about the money. We always start with the money. Why don't we start with ambitions? What's social care for? What aims? Can't we have ambitions like you do with health? We have ambitions for health. Why don't we have ambitions for social care? I mean, Social Care Futures is a website. They are very much in that sort of. They're thinking very clear. They've got some very clear ideas. More and more working age adults, by the way. Over half of local authority funding is now on adults of working age, not older people. That balance has now shifted. So 51% of local authority funding is on adults of working age. For those people who probably had services from a relatively young age in the main, not all, but a lot of them would have done, they're very clear. Social care is to help me live a full life, to maintain my independence, to have access to jobs, to live well. Those are the sorts of things and narratives we need to bring into our thinking about social care. It's not just the end of the road, what can you afford? It's always somehow about that corrupts a more ambitious, positive discourse. Oh yes, I'm just going to. I love a conceptual model, as you may already know, and we need to shift the lens about health to earlier in the life and about the fact there's lots of tentacles to health and wellbeing. It's not just about the individual and their family. It's about this wider stuff, which I know the ARC and other ambitious frameworks and networks are thinking about. But it's an old model, but I think it's quite. Some of the language is a bit odd as well, isn't it? But it's kind of. I like it. I like it. references and back to the advert for the Sorry about that. Right, thank you very much, everybody.